Lecture will consist of two parts. First of all, I will meet you with information about how to examine urinary system, and after that, I will tell you about main syndromes. So first of all, to begin with this topic, I want to refresh a little bit your knowledge about the anatomy and physiology of the urinary system.
System. The major organs in the urinary system are going to be the kidneys, and their major role is in waste excretion. They're cleaning our blood, and solid waste from the blood is eventually going to leave our body as urine. Now, in addition to doing that, they also regulate blood volume, blood pressure, blood pH. They regulate important electrolytes and metabolites in our body. The kidneys are incredibly important. Without them, you'll die unless you're hooked up to a kidney dialysis machine. But that's going to require going 3 times a week, 4 to 5 hours a day, hooked up to a machine just to clean your blood. Now, in addition to the kidneys, we also have other parts of the urinary system, including the ureter, the bladder, and the urethra. In males and females, the urinary system is essentially identical, except for the length of the urethra itself. Now, what's the role of the kidney? The role is to produce urine. From there, it's transported to the bladder through the ureters, and then from there, it's stored and eventually conducted into the environment. That's how we lose this waste. Now, you might be thinking to yourself, what is urine? Well, urine is mostly water, so 90 to 95% of urine is going to be water, but the rest of it is going to be solid waste, both inorganic and organic. Organic waste like urea, uric acid, and inorganics like toxins and certain salts as well. If we look at the structure of the kidney, on the outside we're going to have the renal cortex. Renal simply means kidney. So we've got the outer layer of the kidney, and then on the inside we have the renal medulla. And then on the center we have the renal pelvis. This is going to be a hollow opening, and this is where all the nephrons are going to enter into. They're going to get rid of their urine, and that's eventually going to go through the ureter. Now, if we look inside the kidney itself, we find the whole thing is just filled with blood vessels. Around 20% of cardiac output is going through the kidneys. So that's a massive amount of blood that's going through the kidneys. How does it do that? Well, it comes in through the renal artery, out through the renal vein, but there's a huge amount of surface area inside the kidneys itself. From there, we go into smaller arteries, and then arterioles and capillaries, and then eventually the blood is going to come out. But the important waste excretion is going to take place as we get to those center blood vessels. So let's zoom into that, and let's zoom into the functional unit of the kidney, which is going to be the nephron. So if we look at where these blood vessels are found, blood's going to flow into the nephron through the afferent arteriole, and then it goes into the glomerulus, or the glomerular capillaries. At this point, you essentially have a dead end. The blood is flowing in, and it comes to a dead end. That dead end is inside something called the Bowman's capsule. At this point, we're going to have filtration occurring. A lot of that blood plasma is squirting out of the capillary, and it's eventually going to move into the urinary system. From there, the blood goes through the afferent arteriole. And so at this point, we've got filtration taking place. This is where we're actually filtering the blood. Now, if you look at the blood vessels, they continue to go and wrap around the rest of the nephron, the peritubular capillaries, before they're eventually going to leave. What's going on all of this surface area is secretion and reabsorption. Secretion is when we're taking material that's in the blood that wasn't filtered out, but we're getting rid of that. And also there's some material in the filtrate, glucose, water, for example, that we want to reabsorb. So we're going to take that back into the circulatory system. So if we remove the circulatory system, now we can kind of see what that nephron looks like. First part's going to be the renal corpuscle right here. If we look at what's taking place there, that's where that filtration occurs. So at this point, we call this a filtrate. From there, it's going into a number of different renal tubules. The first one is going to be the proximal convoluted tubule. Proximal means close to the renal corpuscle. Convoluted means it's just folded over and over in many different dimensions. We're increasing the surface area there. What's going on at this place is that we're reabsorbing important material. We're reabsorbing solutes, water. We're taking that back into our circulatory system. From there, the renal tubules are going to flow down into what's called the loop of Henle. We have a descending limb of the loop of Henle, and during that, we're reabsorbing a lot of the water. And then as we have the ascending limb of the loop of Henle, we're reabsorbing a lot of that sodium and chloride. A lot of that salts are coming back into our body. If we look at where we are inside the kidney itself, As we go down into the loop of Henle, we've entered into that renal medulla. And if you think about what's going on as we move farther and farther down, we've set up a countercurrent exchange. What we're doing is we're increasing the salt levels as we move farther and farther down into that renal medulla. That makes it easier for us to take back more of that water in the descending limb of the loop of Henle and also in the collecting duct. From there, we're moving into the distal convoluted tubule and then into the collecting duct. If you think about where this collecting duct is going, you can see that we're getting a bunch of other nephrons that are connected to it as well. From here, it's eventually going into that center of the kidney, the renal pelvis, and eventually it's going to leave as urine. Now, what's going along in that distal convoluted tubule and the collecting duct is we have variable secretion and reabsorption of solutes and water. So in other words, sometimes we're getting rid of waste and sometimes we're taking that back into the body. Now, a lot of this is under hormone control. So for example, a really important hormone is vasopressin or ADH, antidiuretic hormone. And what that's going to do is it's going to affect the distal convoluted tubule and the collecting duct itself. And what it does is it essentially shuts down the flow of water outside our body. And so we can get a signal. If we sense how much water there is in our blood, we can get a signal that means we have to hold on to that. Or we can have a signal that says we want to release that water and it's eventually going to leave as urine. If we look at where it goes, from here, all of that waste that comes out of the nephron is emptying out eventually into the pelvis, into the ureter, and it's stored in the bladder itself. From there, we can eventually conduct that to the environment. And so that's how the urinary system works. It's really simple. It's also really, really important. And
All right. So each of us must understand how huge is this problem, which is called chronic kidney disease. The number of patients in the world with kidney disease is growing steadily, and chronic kidney disease affects 1 in 2 people worldwide. So, according to the World Health Organization, it's becoming a major health crisis with significant socio-economic impact. So, this problem plays a role in reducing, first of all, the quality of the life of the patient, and of course has impact on country's economy. One example, hemodialysis treatment, it is one of the possible options of renal replacement therapy. So one procedure of hemodialysis costs $50. For example, this is in Ukraine, yes? So this costs $50 for the government because government is paying by this treatment. And the patient needs at least 12 procedures per month, which means that it costs the government $600 in months. And that is why each of us need to understand that our main task, of course, is to prevent possible occurrence with knowing of causes. And of course, our task is to diagnose chronic kidney disease in early stages. Now, data combined from different studies shows that more than 1.5 million people worldwide are now on the renal replacement therapy. So, knowing of the cause of the possible occurrence of chronic kidney disease is very important. For example, we already know that almost 40% of more than 40% of the people are suffering from the chronic kidney disease because of diabetes type 2. Also, one of the leading causes of chronic kidney disease is high blood pressure level. Besides that, also it may be due to glomerular diseases, or type 1 diabetes, or nephritis, or tumors. That is why each of us, of course, must understand that, first of all, we have to prevent and to diagnose chronic kidney disease as soon as possible in early stages. How can we do that? We can do that very easy with well-done physical examination of the patient and, of course, proper prescription of the instrumental and laboratory methods of examination. So, first of all, I want to begin from physical examination, which as always consists of questioning, general examination, palpation, and percussion of the patient. So first of all, we have here 2 groups of complaints. renal complaints, and external or general complaints, extrarenal. So first of all, renal complaints are pain in the lumbar region, hypogastria and external genitalia, disordered urination, and edema. If to talk about extrarenal complaints of the patient which may occur, so here we have headache, dizziness, deranged vision. Very often it will be in case of renal artery hypertension or due to intoxication. Or your patient may have pain in the area of the heart and dyspnea in case of left ventricular insufficiency as a complication of the problem. Or very often your patient may have signs of uremia in case of end-stage renal disease or before this. So such complaints are itching, weakness, absence of appetite, nausea, and vomiting. And finally, this condition may be connected with inflammation. That is why may be elevated body temperature. Now, about pain in the lumbar region. So kidney pain usually is felt in the flank or back between the 12th rib and the iliac crest, and it may radiate to the epigastric region. Dysuria symptoms. Here we have a lot of specific medical terms. First of all, normally adults void about 4 to 6 times per day, mostly in the daytime, and totally from 700 to 2000 milliliters per day. Pollakiuria is abnormality, which means frequent urination, which is more than 7 and even 8 times per day. Nicturia or nocturia is a condition when the volume of urine excreted during night often exceeds the amount of daily urine. Also, we have different changes of daily urine output. For example, polyuria more than 2,500, oliguria less than 500, and anuria, its absence of the urination or less than 100 milliliter per day. Also, there is such condition which is called ischurria, when the urine is retained in the bladder and the patient is unable to evacuate. Also, your patient may feel pain in urination, which is called stranguria. Also, your patient may have abnormal appearance of the color of the urine, maybe hematuria in case of blood in urine, pyuria in case of pus in urine, exertion of food pigments or drugs, pyuria, cloudy or milky urine. Also, may have urinary incompetence when your patient is having uncontrollable loss of urine, and finally, enuresis or bad wetting. Now, first is, of course, during physical examination inspection. So what can we see in case of kidney problems? Of course, edema. Specific is abnormal phase, which is called facies nephritica. Also, your patient may have pale skin, your patient may feel itching, and you may see that because of the scratches on the skin. Also, your patient may have unpleasant odor of ammonia and coated dry tongue. Now, a few words about facies nephritica. So, facies nephritica is a sign of renal edema characterized by the pallid, swollen face with edematous eyelids and narrowed eye slits. So, this very specific phase of the patient who is suffering from chronic kidney disease. Now, next method of examination which is used is palpation. As always, during palpation, first of all, we try to find painful areas. But with help of palpation of the kidneys, we can assess the shape, the size, the surface of the kidneys, tenderness, mobility, and consistency of the kidneys. In norm, kidneys are not palpable. Perfectly palpable kidneys may be in case of cysts in the kidneys. Also, we may palpate an urinary bladder in absence of its pathology, and its overflow yields a negative result. Next method is percussion. And percussion, we percussing the kidneys to reveal again the pain in the area of the kidneys. This method which we are using is called Pasternatsky method, and we try to check the Pasternatsky symptom. So if Pasternatsky symptom is positive, so patient feels pain during the tapping in the lumbar region. Also, percussion of the superior border of the filled urinary bladder gives a dull sound at the suprapubic region. Now, short video about percussion Pasternatsky method.
Percussion of the kidneys. The kidneys are located in the retroperitoneum and are well protected by both ribs and muscles of the back. The upper pole of the left kidney can be found at the level of the 12th thoracic vertebra. Because of the liver, the right kidney lies around 3 centimeters lower than the left. Careful percussion of the flanks in the lower rib cage area should not elicit pain in a healthy patient. Pain on percussion, however, should raise suspicion for a pathological process such as pyelonephritis or urolithiasis.
Thank you that you informed me that slides are not moving and not changing. Do you see objective examination on your screen?
Yes, ma'am.
All right. Good that you informed me that at the beginning of the lecture, not in the end. Okay, so again, I will not play this video because I don't have enough time for that. So last examination, which can be done, is auscultation. When we talk about auscultation, students, so here it is done, for example, to reveal renal stenosis. So auscultation is diagnostic of kidney disease, is used for recognition of pathology of renal artery. So systolic murmur of renal artery stenosis can be auscultated in the costovertebral angles and on anterior abdominal wall in points placed 5 centimeters above umbilicus and near 4 to 5 centimeters aside. Now, next, our step is, of course, laboratory and instrumental methods of examination. When we talk about laboratory and instrumental methods, of course, first of all, in case of if you suspect some kidney problem, you should start from simple urine analysis. But besides that, also can be done Adiskakovsky test, Nechiporenko method, Zimnitsky test, assay of Reberg, common blood analysis, and besides that, we check blood chemistry. We check in blood chemistry, first of all, glomerular filtration rate. This glomerular filtration rate will be called measured. Also, urine albumin creatinine ratio. Besides that, creatinine, urea, uric acid, may be also checked nitrogen, potassium, sodium, calcium, phosphorus, magnesium, etc. More, we will discuss these methods with you during practical classes. But about some of them, I will tell you today. And besides that, I want to mention that in past, most of us was using creatinine alone to evaluate the chronic kidney disease stage. But in nowadays, we always use the level of glomerular filtration rate to evaluate the chronic kidney disease stage. But if this glomerular filtration rate is checked with help of equations, so it should be based on the level of creatinine. That is why creatinine still is widely used as an indicator of chronic kidney disease. Now, first of all, urine. Average urine output production in adult humans is about 1 to 2 liters per day, depending, first of all, on the state of hydration, activity level, environmental condition, and individual's health. So, producing too much or too little urine, of course, needs medical attention. If to talk about the components of the urine, so it contains nitrogenous waste and unneeded substances. Color, so freshly voided urine is generally clear and pale to deep yellow. When formed, urine is sterile and slightly aromatic, but if allowed to stand, it takes an ammonia odor caused by the action of bacteria on the urine solute. Urine pH is usually slightly acidic, around 6, but changes in body metabolism and certain foods may also cause it become more acidic or more basic. Specific gravity of urine is between 1001 and 1035. And specific gravity means that how good is ability of the kidney to concentrate the urine. And finally, solids. Solids normally found in urine include sodium and potassium ions, urea, uric acid, creatinine, ammonia, etc. So, in 24 hours, kidney filters some 150 to 180 liters of blood plasma through their glomeruli into the tubules. And now, let's talk about a little bit about glomerular filtration rate. This is the most common indicator which we have to check. It may be checked in two ways. First of all, it may be measured in the blood plasma, or it may be calculated with help of equations, which are developed by different organizations. So first, what is glomerular filtration rate? So the amount of filtrate produced every minute is called the glomerular filtration rate, or GFR, and amount to 180 liters per day. About 99% of this filtrate is reabsorbed as it passes through the nephron, and the remaining 1% becomes urine. So glomerular filtration rate is equal to the total of the filtration rates of the functioning nephrons in the kidneys. Glomerular filtration rate is considered the optimal way to measure kidney function. And on the right of the slide, I show you the stages of the chronic kidney disease, and this classification is based on the glomerular filtration rate numbers. So, when we talk about glomerular filtration rate, it is widely used, first of all, in detecting kidney disease, in understanding its severity or progression of the problem, making decision about diagnosis, prognosis, and treatment, and detecting of chronic kidney disease progression. Normal glomerular filtration rate varies according to age, sex, and body size. And all these things we take into account when we are calculating glomerular filtration rate with help of equations. In young adult, it is approximately 120 milliliter per minute and declines in normal individuals with age. Below 60 milliliter per minute, the prevalence of complications of chronic kidney disease increases, as does the risk of cardiovascular diseases. In other words, we can say that on the stage 1 and stage 2, we cannot give any treatment for the patient if not necessary. But from stage 3, we start to treat patients with some kind of medications. And at stage 4, you already will have to explain your patients that patients should be prepared for possible hemodialysis treatment or treatment with help of peritoneal dialysis. But stage 5, where glomerular filtration rate is 15 and less, needs treatment, renal replacement therapy, which most common method is hemodialysis, and less common but also widely used is peritoneal dialysis. But one more option also is transplantation of the kidney, but not everything is so simple with this treatment method. So first of all, now measuring glomerular filtration rate. So the gold standard for measuring glomerular filtration rate is using plasma or urine clearance for an exogenous filtration marker. However, this is a complex procedure and generally not routinely performed. Therefore, estimated glomerular filtration rate is usually estimated from the person's serum creatinine and or cystatin C level. One more indicator, which is nowadays also widely used to evaluate the condition of the kidneys. So in combination with demographic factors such as age, race, and gender using an estimating equation. On the right of this slide, you can see different equations which we are using to calculate estimated glomerular filtration rate. And the most common used are modification of diet in renal disease formula, which is called MDRD, and chronic kidney disease epidemiology collaboration formula, which is also called CKD epi. So these two equations are the most common used, but also here we have another equations which may be used. And most of them are based on the result of creatinine, but as I said, also widely used now in cystatin C2. That is why there are developed and also equations for measuring glomerular filtration rate on the base of cystatin C. But according to the new recommendation, best is to calculate glomerular filtration rate on the base of and of cystatin C and of creatinine. And besides that, measure glomerular filtration rate in the blood. Now, what if glomerular filtration rate is normal? Because it can happen when, if you saw in the classification on the stage 1, there is absolutely normal glomerular filtration rate, but still you suspect that patient is having already some kind of the kidney condition. In this case, the most common one is used urine albumin creatinine ratio. So it is an early sign of kidney disease. And 3 high results for 3 months or more is a sign of kidney disease. A normal amount of albumin in urine is less than 30 milligrams per day. Anything above this number may mean that patient have kidney disease, even if he or she estimated glomerular filtration rate number is above 60. Or patient is having perceived a glomerular filtration rate. So besides that, of course, you have to check and glomerular filtration rate too. Now, how can we help our patient at the beginning? We can prescribe nephroprotective treatment. In nowadays are invented new specific drugs about which we will talk with you during practical classes. But I have to say that most common one and that which are used already for a long time are ACE inhibitors and angiotensin receptor blockers. Yes, they are antihypertensive drugs, but they showed a very good nephroprotective effect. So in small doses, they may be prescribed to protect kidneys and to prevent possible occurrence of progression of the chronic kidney disease. Now, instrumental methods. So what options do we have here? On the first place is ultrasound. Ultrasound is also, as always, is absolutely safe method of examination, easy to perform for the patient, not painful. And ultrasound can show us, first of all, possible accumulation of the stones, cyst in the kidneys, the size of the kidneys, the size of the parenchyma, and other abnormalities. Besides that, also kidneys may be checked with help of a plain X-ray of the abdomen and intravenous urography, retrograde pyelography, renal angiography if necessary, if you suspect stenosis of the renal arteries. Also radionuclide scanning and, as always, CT and MRI. And now, before I will continue, I want to ask you students, please, everyone who are present, put a plus in the chat. Again, students, everyone who are present, please put a plus in the chat. Now, main syndromes in disease of kidneys. Here we distinguish next syndromes: urinary syndrome, nephrotic and nephritic syndrome, syndrome of renal edema, renal artery hypertension syndrome, acute renal failure, and chronic renal failure. First, urinary syndrome. What should we know about it? It includes symptoms of dysuria and pathological properties of urine. So, what do we know? First of all, urinary syndrome includes proteinuria, but in this case, protein in urine will be less than 3 grams per liter. Urinary sediment abnormalities such as hematuria, leukocyturia, and abnormal amount or type of urinary cast also is specific sign of this syndrome. So its diagnostic value is next. It's particularly high in the absence of extrarenal symptoms of kidney disease such as edema and hypertension. When changes in the urine are the only diagnostic criteria for renal or urinary tract disease, such as, first of all, chronic pyelonephritis, glomerulonephritis with isolated urinary syndrome, because for glomerulonephritis more common is nephrotic or nephritic syndrome than urinary syndrome, and at initial stage of renal amyloidosis. Now, clinical picture is characterized by dysuric symptoms, including disorder in the daily volume of excreted urine, rhythm and character of urination, such as pain in urination, pollakiuria, polyuria, oliguria, and in some cases even anuria, and finally nicturia or nocturia. Next syndrome is called nephrotic syndrome and nephritic syndrome. What is the main difference between them? That in nephrotic syndrome, more pronounced is proteinuria. In nephritic syndrome, more pronounced is blood or hematuria. So the key with nephrotic syndrome is an excess amount of protein in the urine, whereas nephritic syndrome is where there is an excess amount of blood in the urine. So the many different causes of glomerular disease, such as glomerulopathies, can be generally classified into one of three major syndromes: nephrotic, nephritic, and asymptomatic renal diseases. Now, what should we know about nephrotic syndrome? So nephrotic syndrome also increases the risk of thromboembolism and hyperlipidemia. The patient will present with a triad of symptoms. Triad is massive proteinuria, which is more than 3.5 grams per day, hypoalbuminemia, serum albumin less or equal 30 grams per liter, and as a result of hypoalbuminemia, nephrotic syndrome is associated with, first of all, edema, hyperlipidemia, and hypercoagulability. Now, what may cause this problem? Minimal change disease and immunoglobulin A nephropathy is one of it's a cause in 15% of cases. Besides that, it may be due to diabetes mellitus, amyloidosis, systemic lupus erythematosus, and focal segmental glomerulosclerosis. Next is and fundamental laboratory abnormalities in case of nephrotic syndrome are next: decreased serum albumin, decreased total serum protein, hyperlipidemia, elevation in the blood urea nitrogen and creatinine, and in this case, students, glomerular filtration rate may be normal. Now, next is nephritic syndrome. The main difference between this and nephrotic syndrome is that the nephritic syndrome hematuria is present. So the patient will present with next symptoms. On the first place, hematuria. Can be flank hematuria as visible or microscopic. Red cell cast in urine, mild to moderate proteinuria. Typically, in this case, the amount of protein is less than 3.5 grams per liter per day, which is like in urinary syndrome. Now, also maybe hypertension, oliguria, edema, and uremic symptoms, such as reduced appetite, fatigue, itching, and nausea. Now, is characterized by inflammation of the glomeruli, such as glomerulonephritis, and renal dysfunction. The most common causes of this syndrome may be immunoglobulin A nephropathy, post-infections, glomerulonephritis, and lupus nephritis. Now, nephritic and nephrotic syndromes refer to clinical presentation of renal disease, specifically glomerulonephropathies. Both terms refers to a collection of symptoms rather than a true diagnosis. Overlapping of the two syndromes is possible as nephrotic syndrome may precede nephritic syndrome, although not vice versa. Next syndrome is called syndrome of renal edema. And the renal edema is syndrome of general disorder of water salt metabolisms specific to most kidney diseases and can easily be differentiated from edema of other origin, for example, cardiovascular problems. And now, what clinical features is having renal edema? First of all, may be pale skin above edema. more expressed at morning hours, can develop and resolve quickly. In pronounced cases may occur anasarca or edema of the whole body, enlarged liver and fluid in serous cavities such as ascites, hydrothorax, and maybe. And the enlargement of the liver is usually proportional to enlargement of the other organs. And the most important is facies nephritica in this case. Next syndrome is called renal artery hypertension syndrome. And what it is symptomatic hypertension due to kidney problems. So renal artery hypertension, it is a symptomatic hypertension caused by the affection of the kidneys or renal vessels and upset renal mechanism of arterial pressure regulation. The renal hypertension syndrome can be of a primary significance in the clinical picture of the disease and can be decisive for its course and outcomes. So, what are most common causes of this problem? Acute and chronic glomerulonephritis, pyelonephritis, nephrosclerosis, various affection of the renal blood vessel. Important role of the kidneys play in the regulation of arterial pressure due to increased renin secretion. However, less than 5% of adults hypertension is due to kidney and renovascular problem. Now, clinical features of this kind of problem will be next. First of all, high blood pressure, of course, but in this case will be very high diastolic pressure and low pulse pressure. Also, for this type of arterial hypertension are less common hypertensive crises. Besides that, this problem can lead to complications such as ventricular hypertrophy or injury of the retina or injury of the brain. So due to that will occur and complications related to these organs. Besides that, pronounced urinary syndrome, often previous to the high blood pressure. Serious changes in functional tests of the kidneys will be, of course, observed. And finally, urinary and kidney disorder in past history, often previous to the high blood pressure. Now, screening tests which should be used in diagnosing renal arterial hypertension. Simple urine analysis, Nechepurenko test, Zimnitsky test, blood serum urea and creatinine, assay of the Reberg to measure the glomerular filtration rate, ultrasonography of the kidney and, if necessary, urinary pass. Besides that, special tests required for diagnosis of the underlying disease, and they may be intravenous urography, radioscope renal angiography, renal puncture biopsy, if necessary. It is necessary in case of diagnosing of glomerulonephritis to specify what is the type of it is. So diagnosing of the renal artery hypertension is supported by typical clinical features and laboratory instrumental findings that confirm pathology of kidneys and renovascular problems. Now, as a complication of renal artery hypertension, here we have angina pectoris, renal retinopathy, deranged vision, disorders in cerebral circulation, it may occur even with paralysis, dysfunction of pelvic organs, myocardial infarction, heart failure, etc. Next is acute renal failure. And what should we know about it? That acute renal failure also is called acute kidney injury, so it is a synonym. And it is defined as an abrupt or rapid decline in renal filtration function. It is a sudden episode of kidney failure or kidney damage that happens within a few hours or a few days. Acute kidney injury causes a buildup of waste products in the blood and makes it hard for the kidneys to keep the right balance of fluid in the body. So acute renal failure is toxicosis of the body caused by rapid, from days to weeks, steadily decreasing renal dysfunction, which is azotemia, with oliguria. We have two classifications of acute renal failure. First, according to the course, when here we distinguish pre-renal, renal, and post-renal acute renal failure. And according to the stage, we distinguish 4 stages. Initial stage from several hours to 6-7 days, oligoanuric stage, polyuric stage, and finally, recovery stage, or normalization of diuresis from 3 to 12 months. So, in other words, we can conclude that acute renal failure can be cured, and this is good news. Now, clinical picture. Acute renal failure varies slightly depending on the character of the main disease. The most important clinical features are rapidly development of oliguria or even anuria, azotemia, and finally proteinuria, cylindruria, and erythrocyturia. Now, diagnosis of acute renal failure is based, first of all, on a progressive daily rise in serum creatinine accompanied by oliguria or anuria. Characteristic laboratory findings are progressive azotemia, acidosis, hyperkalemia, and hypernatremia. And now, ultrasound examination. It is very important method in this case because it helps us to distinguish is it acute renal failure or is it already chronic kidney injury. So ultrasonography or CT is helpful because a normal or enlarged kidneys favors reversibility, whereas small size suggests chronic renal insufficiency. So ultrasonography can show urinary obstruction besides that, and renal arteriography or venography may be indicated if vascular causes are suggested clinically. And last syndrome is called chronic renal failure. What should we know about it? First of all, chronic kidney disease is a type of kidney disease in which a gradual loss of kidney function occurs over a period of months to years. The term renal refers to the kidneys, so another name for the kidney failure is renal failure. Mild kidney disease is often called renal insufficiency. There are a lot of reasons which can lead to chronic kidney disease. Diabetes mellitus and type 1 and more common type 2. High blood pressure, high cholesterol, heart disease, liver disease, amyloidosis, sickle cell disease, systemic lupus erythematosus, vascular diseases such as arteritis, vasculitis. Also, use again of anti-inflammatory medications and a family history of kidney disease. And what do we have here? First of all, there is special organization which is called National Kidney Foundation. And this National Kidney Foundation defines chronic kidney disease on the basis of either of the following. First of all, evidence of kidney damage based on abnormal urinalysis results such as proteinuria or hematuria, or structural abnormalities observed on ultrasound images. Besides that, glomerular filtration rate of less than 60 milliliter per minute for 3 or more months. And in accordance with this definition, the National Kidney Foundation developed guidelines that classify the progression of renal disease into 5 stages, as you can see on the right of this slide. From kidney disease with a preserved glomerular filtration rate to end-stage kidney failure. This classification includes treatment strategies for each progressive level as follows. Now, what should we know? First of all, Stage 5, what it means, that glomerular filtration rate will be 15 or less. In this case, nothing will help except renal replacement therapy. Renal replacement therapy may be or hemodialysis or peritoneal dialysis, but hemodialysis is more common way of the treatment. But on the stage 4, yes, your patient is still not needed this treatment, but you already will have to explain that patient will need to think about this way of the treatment, and best will be, of course, to with help of surgical operation to make assess for this hemodialysis treatment. One of the most common ones, is arteriovenous fistula. About this fistula, I will show you on the next slide. On stage 2 and 3, the problem can be treated with help of some medications and especially with help of nephroprotective drugs. Now, next, what I want to show you is what will happen with your patient at end-stage renal failure, when glomerular filtration rate is 15 and less, and when your patient is already treated with help of renal replacement therapy. So each of the systems of the body will be injured. Your patient will have neurological problems, cardiovascular disease and disorders, may occur pulmonary abnormalities, also gastrointestinal disorders, also psychological problems, also hematological problems, skin disorders, and even musculoskeletal disease. And now, students, when you are examining patient who is treated with help of hemodialysis, those students who was working with me previous semester, saw hemodialysis department, so they saw how look like an arteriovenous fistula. And you have to remember that never take blood pressure or obtain blood samples from extremity that has access site. Now, again, what are treatment options? Treatment options for chronic kidney disease, of course, drug treatment. But at end stage, nothing will help except hemodialysis or peritoneal dialysis or transplantation if possible. Here I show you hemodialysis, how it look like, and peritoneal dialysis as a possible way of the treatment of renal replacement therapy. Now, chronic renal failure, a little bit about vascular access. So what possible ways are? First of all, the most common way is called arteriovenous fistula. Besides that, may be formed arteriovenous graft, and if your patient was not prepared for this condition, but it is necessary to perform hemodialysis for this patient, you can use central venous catheter, but central venous catheter increases the risk of infections. That is why if you know that your patient is having chronic kidney disease end stage, you of course will need to recommend your patient to make this surgical operation and to have this arteriovenous fistula. Otherwise, your patient may be infected due to the central venous catheter use. So a vascular access is required for hemodialysis so that blood can be moved through the dialysis filter at rapid speeds to allow clearing of the waste toxins and excess fluids. And now again, this how look like this arteriovenous fistula. And an arteriovenous fistula is an abnormal connection of passageway between an artery and a vein, and it is surgically created for hemodialysis treatment. Now, next option is peritoneal dialysis. Yes, your patient will not need to go to the hemodialysis center for treatment. And peritoneal dialysis also must have some access. So a catheter is implanted into the abdominal cavity, lined by the peritoneum by a minor surgical procedure. But again, it may cause a lot of problems and mainly infection. And last option for the patient, most often, of course, the best way, is kidney transplantation, but not everything is so simple with this method. Yes, kidney transplantation offers the best outcomes and the best quality of the life. Finding a willing living kidney donor is an alternative to waiting for a compatible deceased donor kidney to become available. Family members are often the most likely to be compatible living kidney donors, but the new kidney may be rejected. First thing, rejection is absolutely normal reaction of the organism. And when a new kidney is transplanted into the recipient bodies, the immune system reacts to what it thinks as a threat and attack the new organ. That is why, due to that, to avoid this possible abnormal outcome, of course, should be prescribed some treatment, medications. These medications are immunosuppressants. And again, these immunosuppressants increase the risk of infection. So what other complications may be due to this operation is bleeding, blockage of the blood vessels to the new kidney, leakage of urine or blockage of urine in the ureter, and a lack of function of the new kidney at first. Now, concluding mentioned information, students, and summarizing information about acute and chronic renal failure, I need to say that, first of all, acute renal failure is a sudden loss of kidney function caused by an illness and injury or a toxin that stressed the kidney. But in this case, kidney function may be recovered. Chronic kidney disease, it is a long and usually slow progress where the kidneys lose their ability to function. And this is that part of our work when we are able to prevent possible chronization and progression of it to the end-stage renal disease. Because end-stage renal disease, when the kidney have completely and permanently shut down, nothing will help, just renal replacement therapy, which costs a lot of money, mostly for the government. Now, concluding mentioned information, our task as a doctors, first of all, is to prevent. Second thing, if it is not possible already to prevent, to diagnose the problem as soon as possible in early stages. Because the prevalence of chronic kidney disease worldwide is 10 and 4%, 10 and 4 among the men, and 11.8 among the women. And 1 in 3 adults are at risk of chronic kidney disease. And if your patient is already treated with help of hemodialysis or peritoneal dialysis, it reduces the quality of the life of the patient. And this is a big problem, and for the patient and for the government. Now, students, I ask you, please put plus in the chat. Do you have any questions for me?
No, ma'am.
All right. If you don't have any questions, more about methods of examination and their possible abnormal results, of course, we will talk with you during practical classes. So thank you very much, students, for your attention. Have a nice weekend ahead and see you next time. Bye-bye.
Bye, ma'am.
Thank you, ma'am.
You're welcome. Thank you too for attention.